and thank you so much for joining us today for the webinar Narrow Diameter Overdenture Implants, Theory, Procedures, and a Contemporary Guided Surgery Solution for Simplifying Surgical and Prosthetic Therapy. It is my great pleasure to introduce to you Dr. Michael Shearer, who is going to show you today the surgical procedures related to proper implant placement for narrow diameter implants. Dr. Michael Shearer is currently an assistant professor in residence at University of Nevada, Las Vegas, an assistant clinical professor at Loma Linda University, and a fellow of the American College of Prosthodontists. He has published articles related to clinical prosthodontics and implant dentistry and completed a master's degree related to implant overdentures with multiple publications pending. As an avid technology and computer hobbyist, Dr. Shearer's involvement in digital implant dentistry has led him to develop and utilize new technology with CAD/CAM surgical systems and implement student-facilitated CBCT implant planning. Dr. Shearer serves as a director of the implant dentistry curriculum at UNLV and is actively engaged in guided surgical placement and prosthetic restoration of implants. We would like to thank Zest Anchors for providing an educational grant which makes this lecture possible here today. Please go ahead and use the chat box to send your comments and ask questions during the presentation, and Dr. Shearer will respond to all of you at the end of the lecture. And now, without any further delay, please help me welcome the expert himself, Dr. Michael Shearer.
Well, I'd like to take this opportunity to thank everybody for allowing me to spend some time with them this evening. I know on the East Coast it's late, so thank you for introducing me and allowing me to come into your homes. And here on the Pacific Coast it's 5 o'clock, so thank you for allowing me to come into your offices. Today's presentation is going to be talking about the Zest Locator overdenture implant system. We've already covered more or less my professional background in my introduction, but what I did want to point out here at the bottom of the slide is my email address in case any of you at the end of this presentation wish to reach out to me about any clarification or anything that I may provide for the best purposes of treatment planning as well as executing implant overdentures in your practices. Just a quick disclosure, even though I am a faculty member at the UNLV School of Dental Medicine and Loma Linda School of Dentistry, I do not make any association of an endorsement from any university for its contents of this presentation. I also like to acknowledge Zest Anchors and DTStudyClub for making this event possible. I'd also like to acknowledge Dr. Andrew Engel as my partner in crime at UNLV, and just a wonderful resource that he and I go back and forth treatment planning and really picking each other's brains about how to best make Zest LODI implant overdentures possible, as well as the students that I actively engage with in contributing to this presentation. So one thing that we talk about in complete dentures and the traditional modality of treatment planning for any of our patients that are completely edentulous, we know that yes, the complete denture is really the traditional modality. And what we do know is that yes, ridge resorption decreases the amount of support and stability available for that mandibular denture. Because what happens is that if you look at the situation where a patient has their existing dentition, you remove the dentition, and then almost immediately within the first 3 years, you get a significant amount of bone resorption, both in the maxillary arch and in the mandibular arch. And what can be relatively striking here as well is that you get a significantly greater amount of resorption in the mandibular ridge. And that continues over time, almost at ½ millimeter a year, up to 20 years and beyond. But what's interesting to notice is the maxillary ridge does have a relatively negligible progression of alveolar resorption as compared to the mandibular ridge. Because really, if you break it down and you look at where the original tooth position is in relation to the newly repositioned alveolar substructure, you can see that we have a significantly greater problem with the mandibular arch. We do know that yes, residual bone loss is up to 2 times greater with complete dentures versus the use of an implant overdenture prosthesis after 5 years, and this has been pretty well proven. We also know that the US population is really expected to forecast to grow. We know that we're going to be into the baby boom generation, that you're going to get an explosion of patients in this population age group that could best utilize any sort of implant overdenture prosthesis, because really an estimated 33% of the US population over the age of 65 is lacking all of their teeth. And this accelerated growth is happening right now if you look at where we approximately are right now. Because once we hit the year 2020, you think, okay, well, 2020 is going to come around. We're going to have the latest and greatest and newest in technology. Well, we have that today. And our patients that are in this age core group, we know that we can help them, and it's just going to continue to grow. We know that, yes, if you spend enough time treating the edentulous patient, that one of the greatest challenges that we have is to provide a removable prosthesis with adequate retention and stability. Because what we don't have happen is a patient that is like this. They're out with their grandkids, they're out with their family, or they're out with their friends, and something like this happens at the movie theater. Never a good situation. Because just the simple addition of 2 implants in the interforaminal region of the anterior mandible can dramatically increase the retention of complete dentures. And this is kind of a duh statement for many of people in this room, that we know that we've treated patients with this type of paradigm and this modality. This is obvious. But what we sometimes fail to realize is there's been some literature talking about patients that are best suited for the use of implant overdentures. And what we find is the patients that are in this age group, or pardon me, not this age group, but this clinical presentation group, tend to benefit the greatest from the addition of implant overdentures. But the question is do these two as well? Well, that's sort of a lecture for a different day, but what we're going to talk about is the patients that are in the need for improved stability of their complete denture, because these typically are the major reasons of why we would want to see the benefit coming about of the use of implant overdentures. But really what it comes down to is that ultimately our patients get an enhanced quality of life. That quality of life is really a very difficult measurement to quantify. And it's very difficult to also assess in the dental literature. But anybody who has effectively treated implant overdentures in their practice for some time, we know that that is a significant factor related to their improvement of quality of life. Because this is the big problem with what we see with mandibular complete dentures. And this is just one of the many examples that we see clinically when a patient does not have any sort of implant anchorage or stabilization device. Now, yes, okay, they have cheek retractors in. It's a kind of an extreme example, but this is what's happening whether we think it or not, whether we best balance our occlusion. We have the best bilateral balanced occlusion in the world. The mandibular denture is a major problem. And really, just with the small addition of implants, a minor investment, you get a huge improvement in the amount of stability of that prosthesis. Because stability is such a critical factor in relation to the implant overdenture and the implant prosthesis and its effect upon the existing denture. Because the better that we can improve stability of our prosthesis, the better long-term success that we're going to have. And we know that, yes, our patients who choose implant overdentures over complete dentures tend to report greater satisfaction. But what we sometimes don't know is if we look at some of the studies that have evaluated the metrics of cost, that they still choose the same exact satisfaction index, and they would choose it all over again, despite a higher cost. And that's interesting too, because many times we get patients that come to our offices that say, you know, doc, I just can't afford it, or I don't know if I want to spend the money where I can make a plate that fits just good and just well enough. But reality, what is showing us is that when looking back at these patients and looking at the cost, they still would choose the same treatment despite their higher cost. And now we look at the entire spectrum of the different dental implant companies, just a small snippet of what is possibility in a worldwide population, and it can get really pretty daunting. But what's interesting is we have to ask the question, what do most of these systems have in common? Well, it's very simple. Most of the systems have this in common: the locator attachment. It is the #1 most popular attachment present in the United States, and for very good reasons. And clinicians love this attachment because of several different designs and features that we're going to be talking about in just a few minutes. Because yes, it's important. The implant is really quite important. But ultimately, the business end of what's going to be affecting stability and retention, the effect of that prosthesis in terms of improving our patient's quality of life, is going to be the attachment. Because the patient doesn't know what's inside of their lower jaw. They can see that little plug sticking out on top, and they know that that's the part that's going to be allowing them to have improved stability and retention. And kind of one thing that Zest likes to talk about is this is a proven attachment. It's incredibly popular, and as we can see here, there's millions of satisfied patients, and it's been proven. It works well. And it's been over and over and over again vetted as the most popular attachment for many, many good reasons. So if we look at how a locator functions, a lot of us don't necessarily understand that yes, the locator does tend to snap into place. But what happens when that little snap occurs? Are there anything other that is happening inside of this attachment? Are we concerned about any sort of movement with the denture? Well, a lot of people don't recognize that when a locator attachment snaps into place like you see here, there is a pivoting motion that's occurring. And that pivot is occurring at this little nipple and around the space around the attachment. And I'm going to go through and just kind of accelerate that. And you can see here, this allows for resiliency of the attachment. The resiliency is inside of this space. But what's key here is that if that cap were not there, this is just showing you that how the locator male insert is attaching to the attachment. It's rigidly attached to the attachment, where the locator housing cap is actually rotating on top. And why is that important? Well, it happens to come down to the fact that when we think about how these things wear, the company has said, yes, the engineering is going to happen where the wear is going to be occurring between the top portion of the cap and not the inside portion or the business end. And that's why you don't tend to see a huge amount of wear of the actual nylon insert over time as compared to some other types of attachments. Now, Zest anchors will absolutely tell you that yes, this is a wonderful attachment because it allows for up to a 40-degree divergence when using an extended range male. But what I can tell you is that this can get you into trouble sometimes. It will allow you to have situations where you have to use an angled attachment in a given clinical situation, but I always advocate, always keep your implants as parallel as possible. And it's very important to be parallel, even with a locator overdenture. Because yes, we can do it. This clinical situation will absolutely work, and it'll probably work better than most other attachments, but you'll see some increased mechanical wear, as opposed to if something were a lot straighter. So it's something to think about for your clinical decisions. And I really caution you against using an analog. Like you see here, these types of attachments are not like locators, as much as some people will espouse and they will say. And people a lot of times will purchase these attachments and say, gosh, what went wrong? But if you look here, there is no resiliency built into the system. The resiliency is down in this plastic part, into the attachment. So you'll have actually an increased amount of wear in this area, as opposed to engineering wear to occur in an area that is not clinically as significant. So it's something to think about. So really, they thought of this and they said, well, what's the logic behind having a small diameter implant, the locator overdenture system? And this is really it. They saw a need in the marketplace, which is narrow diameter implants, in combination with the #1 attachment in the country, and they basically came up with a small diameter implant that hits a lot of really wonderful key points. And me being a prosthodontist, I can evaluate implants very critically and make determinations on the fact that yes, this hits many of my requirements, which is #1, a two-piece design. So if the locator attachment wears, which they do occasionally tend to wear, I can very easily service this attachment, as opposed to a single one-piece implant, with wear in this area is more or less new implant time. So I asked you the question, really, if you're placing small diameter in your practice, I really encourage you to seek out a solution that has no compromise, because what we see in the mouth is that a 3mm difference in height can mean the difference between success and compromise. And we know that yes, the O-ball attachment can wear over time, but then what? What do you do? Do you have a contingency plan? Do you have a backup? Well, the answer is most likely not. Because yes, the placement protocol fits one and all size and designs. And this implant tends to also be one implant for all reasons, whether it be fixed or removable. And what I love about this particular implant in this design is that it does one thing extremely well, which is an implant overdenture implant, as opposed to a jack of all trades. Now, unfortunately, this is one of the things that I see in my clinical practice here in Las Vegas. I have an opportunity where I get to really evaluate a lot of problems associated with implant overdentures. And this is just a small snippet of the problems that I see in my current position. What we see is just inaccurate treatment planning and lack of respect of prosthetic space. Now, it's a little bit beyond the presentation today to really go into the nuts and bolts of diagnosis and treatment planning of prosthetic space, but what we do know is that when you can have something that is lower and shorter, maybe a little bit wider, you're going to avoid problems that look like this, or a problem that potentially looks like this, or a patient that goes through 4 or 5 dentures because the attachments were too tall. In a side-by-side comparison of these two different implants, we see that yes, the height is significantly different. The draw correction allows for much greater draw. The O-rings tend to be replaced more often, where the long-term durabilities of these attachments really stand the test of time. Interesting note, I treated my nanny, the lady who basically helped me and raised me as a child, over 8 years ago. And I haven't replaced her attachment once. And I treated her with an overdenture Locator attachment. Now, yes, that is atypical. We recommend on average between 6 months and 2 years is the average time for replacement of one of these attachments. But what's important is even if we ignore this right here, what we can see is as a prosthodontist, I get very concerned that yes, I only have one level of retention for this type of O-ball connection. But what happens if your patient says, gosh, I just don't have enough stability, enough retention. It just moves on me, doc. What's the answer that sometimes other people give you? Well, let's add more implants. Well, that's kind of crazy, where all I can do is say, yes, I'm going to change out your attachment and put in something a little bit tougher, a little bit stronger. And then all of a sudden, you're the hero. So if you have retrievability, nope, you got to take the entire implant out. But in this case, if you do have attachment wear, you can replace that. Or say you now want to go to a taller attachment than a shorter attachment. The implant is placed according to where the implant should go, not where the attachment should go, because you have two different cuff heights. The cuff height is incorporated into this collar and cannot be changed. As I mentioned, there are two different cuff heights. The titanium grades do vary amongst different implant companies across the world, where the Zest LODI implant is a titanium alloy implant, the strongest type of metal used in implants. So here's some basic considerations for any small diameter type of implants. What we know is we have to ask the question, does the patient have adequate bone? Are there considerations for minimizing your invasiveness during your surgical procedure? Are there financial considerations that might preclude that patient from going into traditional implants? Because there's some things I'm going to show you in this presentation that might be able to hit on all three of these things in your clinical practices today. So just some practice sense. We know that, yes, there's growing awareness and market growth of narrow diameter implants. People are coming in asking for them because they know they work. And our current patient base of existing denture wearers are present already in your practices that can capitalize on the fact that, yes, they're there. You just got to treat them. How many patients in your practice have you looked at and gone, well, I just don't think your ridge is wide enough. We're going to have to do extensive bone grafting. Oh, but doctor, I'm 78 years old and I don't know if I want to do that. Now you have a solution. It does tend to be more economical than conventional implants, but key, it many times can be less invasive, leading to a faster recovery. Hey, that's a winner right there in my book. So let's talk briefly about some of the components of the Zest Locator overdenture implant, because it breaks down into more or less a three-piece design. You see here that, yes, it has the lowest vertical height for improved denture strength. Durable self-aligning resilient male insertion connection, 2 available cuff heights for flexibility, as we talked about, a proven surface on the entire length of the implant, self-tapping aggressive thread design. So yes, you could undersize your osteotomy based upon your clinical situation here. You have a self-tapping design that will allow for increased implant stability. They do come in 2 different diameters, either a 2.4 or a 2.9. There's 3 different lengths, allowing for greater versatility, 10, 12, or 14. What I can tell you in my clinical practice is that 12 millimeter implants are generally the go-to implants for me. I tend to stay away from the 10 millimeters unless I have anatomy that I have to avoid. And the 14 millimeter implants do have their place in certain situations, but for the vast majority of the time, we're placing 12 millimeter implants. They are removable and replaceable, the 2 different cuff heights we talked about. a textured surface. Restorative components are included. This is key right here. Because as you see here, if you purchase an implant that looks like this, you get everything that you need to convert that patient into an implant overdenture, including the housing and these 3 attachments. And just this processing kit alone can run a significant amount of money. If we were to break down the surgical kit, it's pretty easy and intuitive and safe instrumentation. We have drill with depth markings of different calibers and different sizes. We have drill stops that you can place on this implant. They actually snap into place, and it comes with the kit at no additional charge for increased safety. You have an extender that allows you to reach in tough spaces. You have a rotary tissue punch that allows you to punch and create clean, nice tissue punches. You have direction indicators that will check your parallelism throughout the procedure. A core tool, which we're all pretty much familiar with, but this is the standard tool that you will use for locator attachments. A little gift from the company, a nice torque wrench. Now this torque wrench alone, I had to purchase before we started using the LODI implants from another dental implant company. And this torque wrench alone cost me $750. The torque wrench insert that goes into the torque wrench, the locator driver, and the implant drivers, both handpiece, the ISO latch, and the manual driver, in case depending upon your preference. The drill stops and laser mark depth are what you see here. You have a 6, 8, 10, 12, 14, 16, 18. Now, of course, we're not going to have to go up to 18 in many situations. What we tend to do the vast majority of the time clinically is we use our drill stops, just because it makes the surgical procedure very fast and very efficient, and you don't have to think about this little line as it's spinning around where the tissue is. These drill stops are cross-compatible with all the different implant drills that come in the kit. So you don't need to create an excessive amount of stock in your inventory. As I mentioned before, all of this comes in all-in-one type pricing for a low cost of $159 US retail list price. As I mentioned before, it comes with an implant of your choosing. You can have either a 2.4 or a 2.9 diameter implant of 10, 12, and 14 millimeter lengths. And you can also specify if you want one of those implants to either come with a 2.5 millimeter cuff height or a 4 millimeter cuff height. Irregardless of what you decide to choose, this is what you get with each and every implant, everything that you would need to pick up the attachment in the mouth. One neat thing that Zest will also do for you is there is an in-place marketing program. And this is available as a link through the Zest Anchor's website. It's also teethinplace.com. And what it is really a turnkey practice marketing program. And what this will allow to do through search engine optimization, you could put your profile onto the website and a link to your practice's website as a way to direct patients over to your practice. So teethinplace.com is a wonderful resource that also comes with a huge assortment of different materials that are available to you, including flyers, brochures, and a lot of different marketing media that can be custom designed to your practice and your logo for an extremely small premium in charge. That's all that information is available on teethinplace.com. So let's go ahead and start with the surgical procedure that is in regards to the Zest LODI implant. So typically what we recommend doing is the traditional methodology is to go ahead and duplicate our patient's existing complete denture in clear orthodontic resin. Now this just shows a very classic approach to diagnosis and treatment planning with a panoramic radiograph. Using ball bearings or BBs of certain diameters, you can then go ahead and say, yes, my BB is 4.5 millimeters in diameter, so right at this vertical height, I can make an estimate based upon 4.5, 4.5, 4.5, etc. It's a very classic way to do it. But there are better and more efficient ways to do it in the year 2014. However, this is an oldie, but still a goodie. So what we're going to do is yes, we're going to take the existing complete denture, and as I mentioned before, we're going to duplicate it. Based upon what we saw with the panoramic radiograph, we can ask the laboratory to place precision guide sleeves or tube sleeves into your surgical guide. But one thing we also really love to do at my two universities is cone beam imaging. And I'm really loving cone beam imaging because it really takes a lot of the guesswork out of panoramic radiology. Because how many times have you opened up a mandibular ridge, if you are placing implants in your practice right now, and gone, whoa, that bone is really not there, what I thought was on the ridge. And really, cone beam imaging is so pervasive in the marketplace that it's almost impossible to not be within a close enough distance to refer a patient to a scan center if you don't have this type of technology in your offices. And what we like to do when we treatment plan cases is we like to use soft tissue separation here. Now what you're looking at is not a barium duplicate of that patient's denture. All we're doing is we're taking the tongue position, the cheek position, the lips, and separating it. So it's more or less, watch me for a second, just going like this and creating an air pocket around the complete denture. And it makes treatment planning so easy and so effective, because if you create this airspace around a complete denture, that's going to allow you to see the outline of the denture, giving you a very good estimate of how much prosthetic space you have and the angulation that you're going to be placing upon the implant. And this is a topic that we'll cover at a later date in subsequent sessions. Here what we've done is we've scanned the patient, done an initial plan, and we've gone ahead and scanned the complete denture. And this is what a regular complete denture looks like in a cone beam scan. All I've done is I've increased the thresholding level or the brightness, and that will allow you to visualize the complete denture. And one trick that I like to do is I like to use a radiographic or radiodense polyvinyl siloxane type material. And that just happens to be the green mousse product, which is a cousin of blue mousse. And what we've been doing lately is we've been doing reline procedures in the patient's existing complete denture. Key is to border mold just like you would be doing for a reline. And what we like to do is again, using that soft tissue separation method, we're going to be scanning with that radiographic, radiodense PVS material in the patient's mouth, soft tissue separation, and we're going to be doing a subsequent scan of the patient's denture only. Now this picture, I do like to go ahead and reorient this while the denture is in the CBCT scanner. So if I'm going to be doing a mandibular denture, I want the tissue side down. However, with some of the more popular implant suites, this is very easy just to rotate around, so it's not that critical. And what we're going to do is we're going to go ahead and upload some of this information to Anatomage, and utilizing this software, we can fabricate surgical guides with great efficiency and with high precision. And now this sometimes can be somewhat difficult for some patients, or potentially too complex for your situation in your office. You say, no, I'm not a computer person. I don't feel comfortable with the imaging software, or I don't want to make a huge investment with the software. There are other resources available, and I've been working with this gentleman here at Reveal Diagnostics, working out some calibration methodologies, and he's got everything really down to a tune and a science. And he's available for discussion and to help you with this cone beam imaging, and is available to help treatment plan your cases, and also to help order your surgical guides at a very low cost. And what we're going to do is based upon that analysis we've uploaded to our imaging service, which is an Anatomage in this case, we're going to be receiving back a plan file. And in this plan file, what we're going to have is a superimposed denture that's going to line up with the existing complete denture in the mouth, as you see here. This outline is so important because if I had the lips touching, you would not see the denture in place. Because what happens is that we know that we can see cortical bone between soft tissue very easily, because cortical bone has a very high radiodensity, where soft tissue has a very low radiodensity that is very similar to acrylic resin, where white space or black space, the negative space, has a very, very low radiodensity. So if we create an air pocket, an airspace around the denture, then we can discern the two very easily. And in this plan, we're going to be able to allow a virtual layer of the patient's existing complete denture. And this virtual layer is going to allow us to manipulate different aspects of our treatment plan. And we can then make sagittal slices, coronal slices, and best be able to make determinations based upon what we think we saw before and then now. So for example, if you direct your attention down in this area, you don't see it as easily here, but you can see that these green lines are going to be indicating your parallel long axes. And what I try to do is I try to line up those perpendicular to the occlusal plane. And by doing that, it greatly enhances your predictability with treatment. Because if we can get the locator attachment to be perpendicular to the occlusal plane, every time that patient functions, it's not going to be incorporating as much potential maintenance and wear as if the implants were tilted like this in relation to the occlusal plane, or in and out motions when the patient removes and inserts the prosthesis. And that's so critical. Because how many times in your clinical practice have you seen, whoa, this patient's going through attachments like candy? Take a look at this. This is a significant factor that can be related to improving your long-term clinical success. So now at this point, we can then receive our computerized surgical guide that looks something like this. And I do tend to prefer to use anchor pins in this case. They're not compulsory. If you in your own practice are comfortable without using anchor pins, that's totally up to your clinical discretion. Also, the Anonymous company is calibrated with the Zest LODI guided surgery methodology. And what we've done is we've helped develop it together is we've said, yes, we figured out a way to use the existing surgical kit to help us guide the implants into place, as opposed to so many other different implant systems on the market that you have to spend an additional $5,000 to $7,000 investing in a proprietary kit that will only work with the guided surgery solution for that one particular implant. Where we've made an investment of this particular guided surgery kit, and now we can place traditional implants and the Zest LODI implants with a high degree of precision. So you ask the question, why should I even bother with computer-guided surgery? Well, that's a very good question. We've done plenty of cases without computerized surgical guides. But we've done quite a few cases with the assistance of a computerized guide. Because it really comes down to these three major things. And we know that safety is often reported as a huge factor. Predictability, in my opinion, is huge. It's absolutely huge, because when we go from our plan to our final result, we know that if I get close to a vital structure that's like this anterior loop of the foramen, I know that I've got a really predictable clinical situation. Because as I try to do things like this where I'm going to maximize the spread of my Zest LODI implants, you can very straightforward achieve this clinical goal. But this tends to break down the barriers for so many clinicians that are listening to this presentation, because I know, even myself, I get nervous for procedures. I'm like, gosh, okay, am I thinking about the anatomy? Am I thinking about this vessel? Am I thinking about this nerve? I'm really going through my checklist and saying, how do I increase my predictability so that way this is taken into consideration? And ultimately, with the use of a computerized surgical guide, this greatly assists this. Precision with a Zest LODI implant is also super critical. Now, are surgical guides perfect? No. As you see here, we did have some minor deflection here. But over time, you can see this minor deflection was very reasonable. We're still way within the bony contours, because when we did our plan, we always take into consideration a safety zone, typically 2 millimeters surrounding an implant. So if we go through the basic surgical protocol, whether it is guided or whether it is traditional, what we tend to do is we want to make sure that we use things that are straightforward and easy. And in this case, what we recommend doing is taking the initial pilot drill, the 1.2 millimeter wide, going at your preferred stop. So since we're going to be placing a 2.9 millimeter by 12 millimeter implant, we're going to be putting on a 12 millimeter drill stop that's going to be contacting the tissue right here, as you saw in the previous animation. And then the next step is to go in with a tissue punch. And when the tissue punch goes into place, it's going to be fed through this channel that you see here. And in a rotary motion, what's going to be happening is that's going to be allowing that tissue cuff to grab in a very clean surgical type incision around that exact space that you want to cuff. And as you see here, now it's using this as a guide for this little indicating pin on the tissue punch. What you're going to do at this point is you're going to use the next size up drill, which is a 1.6 millimeter drill. Using the initial osteotomy as a guide, it will go down a little bit further. And this will allow for a 12 millimeter drill stop down to a full length of a 1.6 millimeter implant. And now many of you who may or may not place an MDI type implant in your practice or other types of small diameter implants, we know that they tend to typically use one drill. And that's a concern for me. It's a significant concern because I want to gradually increase my osteotomy, allowing for those beautiful osteocytes, osteoblasts, so that way we know that all of the cells that are in the periphery around that area are not overheated. It's well controlled. We're not also going to be torquing our implant to the fact where we're going to use a little key and just crank it down until we think it's down all the way. I don't feel comfortable with that. I like a gradual, slower osteotomy because as we go to the final osteotomy, which in this case is a 2.1 millimeter osteotomy, we go down to full depth. What we're going to do is we're going to stop 8 millimeters short. And when we stop 8 millimeters short, it allows for this stepped design that you see here. And that step design is going to effectively allow the implant to grab at 2 different positions. So let's kind of go through a quick example of what this would look like in a computerized surgical guide situation from the example that you saw before. Our first step is really to go ahead and put the anchor pins in place. And just due to the short nature of this webinar, that's not something we're able to discuss at this point. What we've developed is we're going to use this is one way to do it. There's a few other ways to do this, but this is a very straightforward and easy way to do it. We're going to use the 3.8 either insert or the handle that's available from an Automage. We're going to be inserting it into the master sleeve that you see here. And what we're doing is relying upon the drill stop to provide trajectory control for our implant. So you see here, this is our implant drill, the 1.2 millimeter pilot drill. And what we're doing is relying upon the width of this drill stop to control whether it tilts one way or the other. And then you say to me, but doc, what's controlling the most important thing, which is the stop? How do I know if I'm going to stop before a nerve? And that's the genius here. It's so simple. All I'm going to use is I'm going to use the existing drill stop. As I contact bone, it's doing the exact same thing as if you were not using a surgical guide. Safety, predictability, and precision. So at this point, we'll go ahead and we're ready. What I'm not showing in this last clinical slide, just due to time constraints, is we're also going to be using the next size up, which is the 1/6 and possibly the 2/1 drills in the same exact similar fashion. We can also use a tissue punch inside of this wide sleeve that you see here. And we can also place the implant. And I'll show the implant placement in just a second here. But due to time constraints, we're not going to go through each individual step. What's nice about this packaging that they provide through the Zest LODI product is that you can see here it's an all-in-one packaging, as we mentioned before, and it comes in this really sterile type container. And what we tend to do is we tend to rip it open and then drop it on the countertop or on the surgical tray when we're ready to place. What we recommend doing is screwing off or popping off that initial top cap. The latch driver or the hand driver, depending upon your clinical preference, is going to be snapping onto the implant, as you see here. And now, yes, the first thing that you notice is this is an external hex implant. And what that allows you to do, it allows you to snap with a little O-ring that's inside of there. So as this surgeon is going to go carefully lift this implant out on this side, we know that it's not going to fall out. Predictability is so key. And what we're going to do is we're going to place that implant using a tap setting until it stops. I recommend 50 RPMs at 35 Newton centimeters. You can go slower. You can go less torque, depending upon your clinical preferences. This just happens to be the settings that I recommend for this particular implant. What we like to do is we like to go ahead and then snap on the low torque indicating wrench, the ratchet assembly that you see here. You actually want to hear an audible click. That means it's in all the way. And then they make these square drivers that are also compatible with the actual head of the implant. And what this allows us to do, it allows us to then sink the implant down until you get to full depth. And as you see here, the full depth of the implant is going to depend upon what's your tissue height, which you can make a determination based upon your cone beam radiograph. As you see here, I'm just simulating that this tissue is 2.5 millimeters tall, because the height of either the 2.4 or the 2.9 implant is 2.5 millimeters from the platform to the top of this thread, which in my opinion is pretty cool. Because if you're placing a 2.4 millimeter implant or a 2.9 millimeter implant and you are expecting 2.5 millimeters of tissue, you're going to ratchet down until you get just flush with the gingiva. And that allows for the working end to come out for the locator. And at this point, I always like to verify my torque. And this is going to be the discerning factor between whether you're going to load or not load your implant. If I hit somewhere between 30 plus Newton centimeters, we recommend don't taking it above 70. 30 plus Newton centimeters is a compatible loading zone. Now there's some articles that do talk about the possibility of loading at 25 Newton centimeters. However, I would go ahead and be very cautious here and just say yes, 30 Newton centimeters is a very good litmus test for us. Let's go ahead and briefly talk about what we're going to be doing with the denture attachment. What is neat about this implant system, it comes also with the locator assembly that comes inside of that same package. What we tend to do is we like to use this little white cap. And this white cap is also independently sold through Zest, but you get a couple free with your first initial LODI purchase. And that white cap will sit on top of this gold driver tip, where we typically will use to hand tighten down a locator attachment, or you can use it to torque with an 050 hex attachment. But what's neat about this attachment is that you can take any locator, whether it's a LODI or traditional locator type attachment, and this will snap into place. And in my opinion, that's pretty cool. Just like we talked about before, where the actual implant will attach into place with the O-ring, the locator will snap into place, so that way you can actually hold it up and down and massage it. So it won't fall on the patient, it won't fall down onto the tongue, and you, number one, most importantly, won't lose it down the throat or on the ground. So at this point now the attachment is ready to go into place, and you're going to use a hand driver to place the implant abutment. It's going to go away through magic like this, yeah, of course. But anyways, it's going to go away in just a nice easy fashion. At this point you're going to verify your depth. Now what I don't like to do at this point is to torque just yet. What I like to do is I like to make a radiograph, whether it's a few periapicals or a panoramic, which I recommend. This confirms the implant position and depth. And if you look at it and you say, gosh, I'm just not down all the way, I've got some threads exposed. Hey, if you're working with another type of small diameter implant, there's nothing you can do. But with the LODI system, what you can do is you can then say, I'm going to remove this, take it down some more, and put on a taller attachment. That's pretty cool in my opinion. And now once you've confirmed that yes, everything looks good, your prosthetic height is good, you're going to torque the locator abutment to 30 Newton centimeters. And now one thing I forgot to mention before is that if you are planning on immediately loading this and connecting it to the denture the same day, once you get to this point, I like to then verify that yes, they're down all the way. I'll do a lot of my denture prosthetics, like creating that space in that relieving hole inside of the denture prior to torquing. Because if I don't have enough prosthetic space, yes, you can also drop your implant, or you can rotate things around based upon your clinical situation and needs because of the self-tapping feature of this implant. Again, I recommend a torque of 30 Newton centimeters. I know some implant companies might say different things for their locator attachments, but universally across the board, this is a very safe number. As I mentioned before, two different prosthetic options. We can see here 2.5 and a 4mm cuff height. And this allows for a tremendous amount of prosthetic flexibility, especially in maxillary situations. Because I can tell you that this type of height of attachment we've used fairly extensively in maxillary clinical situations because the tissue tends to be a little bit thicker there. It also tends to be a little bit more dense and rigid. Now at this point, as I mentioned before, we're going to verify that everything does clear. And again, I like to do this before I torque. So you can see here now at this point we're going to torque. We're going to attach the white spacers, or if you tend to prefer anything like a rubber dam or Teflon tape, those are all completely viable options, and it's totally up to you and your clinical decision. This is standard locator pickup, what most of you are familiar with. What we're going to do is we're going to verify that yes, everything still fits, like you see here, prior to making any sort of major adjustments. So there's a big difference between this step, which I tend to use like with Blue Moose or any sort of really fast, rigid polyvinyl siloxane. And I don't like to use that same material with these locator transfer caps or the housings because it tends to lock on there and it tends to be a little bit messy and everything. I prefer Fit Checker. You can also use things like wax Rope wax works perfectly fine. Some people use AccuFilm or some of the occlusal indicating paper, perfectly fine. This is just a recommendation. I use this in almost every clinical situation because it gives me a 3D assessment of how much space I have. Now, I always recommend creating relief holes. Now, there's a few different ways to do this. You could, obviously one way to do it is to not create a relief hole, and you just inject a little bit of material and then basically allows the denture to go into place, and then you'll get stuff traditionally will go everywhere. And this is the way that I used to do it. However, almost exclusively, this is the method that I use now. And this doesn't have to be a very big hole. It can be a small hole. And now I know at Loma Linda what we tend to teach a lot of the residents is we use a injection method where we're going to be creating a hole in this surface right here and then a little bit different sized hole on the lingual surface. And you're going to be injecting resin from one side to the other, creating this almost like turbulent flow situation while the denture is fully seated to the tissue. And that works as well. So depending upon what your comfort level is, me personally, I like to use a relief hole. I don't like to put material on the actual housings. I tend to find that it makes it a little bit messy and you tend to overbuild your attachments. One thing that I find that works extremely well in my clinical hands is I pick up all 4 of these at a time. Or if I'm picking up a 2 locator overdenture, I pick up 2 at a time. I know by convention we teach that you should pick up 1 and then 1 and then 1 and then 1, and that turns into a really long clinical appointment. And what I found just from my own personal experience and clinical experiences is that sometimes that one attachment doesn't go down all the way, or maybe when you have 3 of them or 2 of them, maybe over here and here, when you snap that denture into place, sometimes it's not down all the way, it might be funny. Your clinical goal is to ensure that this tissue surface is fully and intimately adapted to the tissue-bearing surface. Now, one thing I will definitely depart from some of the manuals of what you'll see from Zest anchors. This is a little clinical pointer and a tip. I place the denture in place with the resin in this reservoir, and I hold the denture in place. So instead of having the patient bite down, all I do is I grab their mandible, and I grab mandible on each side, and I'll lightly hold the denture in place, just like this, as you see here. And it's a light pressure. I don't want to put a significant amount of pressure because I tend to find that if I have it as a light pressure, it's intimately adapted to the tissues but not overloading the tissues. And ever since I've really adopted this clinical philosophy, my maintenance issues have gone down tremendously. And in many clinical situations where you'll see a patient comes in, they say, "Doc, it's just not fitting as well as it used to." Okay, well, what's your inkling? Okay, I'm going to go ahead. I'm going to remove my locator. I'm going to pop out my attachment. If I got a light blue in there, what do? Let's put a salmon in there or a pink, or let's put a clear attachment. That's not a good way to do it. The best way to do it is to ensure that you have intimate adapted denture to the tissue surface. Because if you have it intimately adapted, then you're going to go ahead and get clinical success. Because this tissue needs to be touching at the exact same time as those locators attached to the attachments, to the locator abutment, to the housing. Because what we're relying upon is that we know that the denture should still have the same denture clinical parameters, which is the primary support area of a mandibular complete denture is going to be what? The buccal shelf. And the secondary area of support is going to come from the alveolar ridge. We don't want a tremendous amount of support to come from the actual locators. The locators are meant for retention. Because if you use them as a more supportive mechanism, you'll get increased wear. Now, yes, when you convert from 2 implants to 4 implants, you do tend to get a significant increase in the amount of support derived from those locators. So it's very difficult to quantify that, but it's certainly up for debate. And now at this point, again, you've got the black processing nails in place here, 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 and here. You can change them out and put in whatever type of attachment you would like to use. Again, the LODI product comes with the blue attachment. It also comes with the pink, and also comes with the red extended range, which is the weakest one. And what I can tell you from our clinical experience, both Dr. Engel and myself, and then various other people that I speak to, we know that yes, the blue attachments do work very nicely, but we've been finding such a huge improvement of retention and stability only with the black processing nails. So I'd say probably 50% of our immediate load patients were leaving in the black processing males. Now, a couple of things I'd like to point out just before we draw this webinar to a conclusion. If you go ahead and redirect yourself to the Zest Anchors website, since this is really an educational webinar, I'm not going to be, using this as a marketing in terms of how many implants you can buy, etc., for special deals. But what I can tell you is that on the website there is a special running right now where you buy 20 implants and then they throw in the surgical kit for free. Wow, that's pretty cool. Because as I mentioned just before, just that torque indicating wrench is almost $700, $750 from some other implant companies. So what you're telling me is that I'm going to buy implants that I'm probably going to buy anyways. They're going to include an entire surgical kit for new users for absolutely free. That's awesome. Not only does it include the torque wrench, it includes the core tool, which is $80, somewhere in that range. And this is a huge benefit for you in your clinical practices because, yes, it is difficult to say, yes, okay, I'm going to have another surgical kit. Do I really need to do that? Can I just buy the drills? Well, we want you to have the kit because the kit will allow you to get yourself out of trouble and it will give you a tremendous amount of flexibility for what you can do for your clinical situations. So it's better to be over-prepared than under-prepared because planning to fail or failing to plan is planning to fail. One thing I'd like to go ahead and announce here at this webinar is that through some support here and in agreement with the Zest Anchors company, we've gone ahead and fabricated a YouTube channel where we have free online surgical and prosthetic training videos. And the concept is called LearnLODI. And we're excited to do this because this is really a neat opportunity for you as clinicians to carry on this presentation because I've already uploaded one surgical video illustrating a guided surgery solution. It's a full-length 50-minute video that will give you a very good amount of background and feedback so that way you can just jump right in to doing your surgeries. Now what we do recommend is we do recommend you to take one of the clinical courses that's offered through Zest Anchors, and we're actively engaging in getting our courses set up here at UNLV as well. So that will be coming also soon across the board. There are also different live surgical seminars that are going to be hopefully coming up within this next coming year. So stay in touch. What I can do is as well give you this link. And here's my email address. I encourage you to go ahead and reach out to me by email. I'm happy to help you with any clinical situation, any case, treatment planning, and whatever I can do to facilitate implant overdenture treatment planning, whether it is only with Zest LODI or with any other Locator product, or frankly any other sort of implant overdenture, as this tends to be my primary research interest as well as my clinical research. And on that note, I'd like to go ahead and thank everybody for your kind attention. We have a few minutes left here for question and answer sessions. And again, I'd like to go ahead and thank the people that made this presentation possible, including Zest Anchors, number one, the DTStudyClub, and then frankly all the people that I have the pleasure of being able to work with at UNLV and then also at Loma Linda. Again, I thank you for your kind attention, and I go ahead and open up the floor to any questions. Okay. So I got one question here that says, what is the cost of the Zest surgical kit? And basically, if you were to purchase this kit independently from just not going through the purchase order, the Zest surgical kit retails for just under $1,200, somewhere in that range. So yes, if you had to purchase an additional kit, that is the price that the company would want to charge there. Another question here is how much does the Anatomage surgical guide cost? The Anatomage surgical guide is a flat fee of $295, and I find that to be incredibly compatible in my clinical practice because reality is that surgical guides can be incredibly expensive. And just a few years ago, they were upwards of $600, $800, almost $1,000 for a 2 or 4 implant surgical guide. And now there are other options available to you on the market. But what I can tell you is that the vast majority of success that I've had with guided surgery has come from the Anatomage Guide. And because they're also using those clinical protocols related to the radiopaque polyvinyl siloxane impression material. Because this software is one of the leading pioneers for using what's called surface-based digital registration. So instead of having to use things like 4 or 6 gutta-percha points at different points along the denture, as you see here, 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 and here, this is a pain in the butt, in my opinion, because number one, I have to take the patient's denture and drill holes into it, which is not that big of a deal. I can pack gutta-percha in there, yeah, sure, no problem. But the problem is that what happens is that when you remove them later on, you're done with your scan or you're done with converting it to an implant overdenture. Now, when you're putting acrylic resin into those new holes, it's very difficult to get the colors to match up. A very particular, very picky patient will oftentimes go ahead and say, "Doc, what is this?" And if you have to put them on the facial of the denture, that's a problem. And what we found is that, again, this is a topic for a different discussion, a different webinar. What we found with the green mousse type of PVS impression, if we inject that into here, we want some show through of it, because that ensures that the guide and the denture is down all the way. We can do our 2 scans, and that acts as the fiducial marker. And that's pretty cool. So no gutta-percha, radiopaque PVS is your fiducial marker. So then the company can then digitally stitch these 2 images together. And the neatest part is that you can take this PVS that's inside of the denture. Hopefully your radiology technician or your dental assistant doesn't go, "Oh, let me help you out, doc, and strip this out." No, don't do that. It's happened to me a couple of times. What you can do is you can pour a snapstone cast inside of that green mousse and then create a solid working model to work off of. Because Anatomage does require a solid cast or an optical STL file of that solid cast. I have another question here. It says here, can I use 2 2.9 by 12 effectively as 4? Yes, we are still working at developing some clinical recommendations. Unfortunately, the literature is not robust in terms of this capacity. We are actively engaging in that sort of discussion at my 2 universities, and what we're finding is that, you know, the general recommendation, my professional empirical recommendation, non-evidence-based, is that yes, I would feel comfortable with 2 2.9 by 12 millimeter implants as opposed to 4. However, if you're going to consider 2.4 millimeter implants, I would definitely go ahead and use 4. We've got another question here. So it says here, after 50 years of practice, I now volunteer at a major nursing home as a consultant. The age and medical condition and lack of funds preclude implants, yet many are able to have conventional diets due to the cornification of the gingiva as they eat with them. But I find your presentation interesting, and I thank you. Well, thank you, Dr. Stefan. One thing that I find very interesting, especially here in Las Vegas, is we tend to have quite a few patients that roll around without any gingiva or without any dentures and just chew on gingiva. And it's always surprising how well those patients eat just on particular without teeth. So it is always a surprise. But you know what's neat about a nursing home situation is that yes, you do tend to have patients that have significant medical issues and also confounding potential medical comorbidity and medical concerns. And if you're going to be looking at this as a very effective solution for minimally invasive surgery, which is possible in many different types of cases, not every case, but many clinical situations, it could be a very effective addition for your patient pool there. So it says here, please repeat the deal of the offer again. On the Zest website, again, this is, I trying not to create this an entire marketing presentation, but what the Zest company does do, it is public on their website. If you purchase 20 different implants or 20 implants of your choosing, and I recommend you mix and match them, some 2.4s, some 2.9s, mostly 10s and 12s, and then I recommend ordering only 2.5 millimeter cuff heights in all of your implants, but I also recommend purchasing a stock of 4 millimeter cuff abutments. And that will allow you to go ahead and then say, yes, I have a clinical situation where I need something taller, and you've got something that is allowing you to do so. So it's really kind of, that's our clinical direction that we're going about right now. So here's one question. How many mini implants are needed for each arch? Can you cut out the palate? Well, the answer is, well, that's totally up to you and your clinical decision. What we find is that on average, we recommend 4 small diameter implants for the mandibular arch, and it's up to you and your clinical decision to either do 4 or 6 for the maxilla. I wouldn't do less than that. You could do 2 if you so choose to do so. However, I would tend to err on the side of more because the bone tends to be softer there. You have less density. The failure is slightly higher on the maxillary arch, as been reported by multiple different studies. Can you cut out the palate? The answer is absolutely. That's your clinical decision. I don't ever cut out the hard palate until the implants are fully integrated. I don't feel comfortable with that. I prefer to leave the palate there until 6 to 8 weeks, and I've assessed that now that we have clinical osseo integration. So I've got a question here. How do I find the schedule of live patient courses? You can go ahead and send me an email and I will be able to follow up on that as well. As we are developing the live surgical courses, those are continuously coming on the market. And we are in the process also of developing a course at UNLV. So here's a great question. Please compare the cost of 4 implants fixed to a 2 implant overdenture. Now, it was a little bit beyond what we could cover in this webinar, in this presentation. However, typically here in Las Vegas, what happens is a 4 implant fixed prosthesis usually runs right around $25,000 to $30,000, including the implants plus the prosthetics. And on average, what we've been charging at the university is abnormally low, so I'm not even going to bother giving you that information. But the clinicians that we use, and in the faculty practices, what we tend to use is, right around $2,500 for the implants all said and done, and then based upon your denture fee. And it's totally up to you, what you decide to charge for your service and what you feel your time and your energy is worth. But at $159 for the implant times 4 is your major overhead cost of the implant surgery, minus your setup, procedures and your disposables, your PPEs, that type of thing, and your clinical time. Ultimately, you'll have to sit down and make that decision. But that's a huge price point comparison, because if you look at $159, which is the implant plus the abutment plus the attachments, if you do just a quick comparison to, say, Nobel Biocare, a major implant company, where just the implant is somewhere right around $350 to $400 for the implant, plus an additional $115 to $120 for the attachment, plus an additional 50-odd some odd dollars for a set of processing package males, you're talking a huge difference in your total investment. So do the math there. You make a decision. Okay, am I still going to charge the exact same procedural fee? That's up to your clinical decision. Okay, here's a great question. Can you flap when placing these implants? Absolutely. What we've been finding at my university and then also in my clinical practice is that we're flapping most likely right around 30 to 40% of the time. And it's, again, beyond the scope of this clinical presentation to talk about the indications of when we flap versus flapless. But what the number one thing and the number one reason of why we would need to flap is if we do or do not have enough prosthetic space. So on average, locator overdentures from the edge of the bone to the top of the tooth, so from here, the edge of the bone, to the top of the teeth, we recommend somewhere right around 9 to 11 millimeters. Now, if you do a quick caliper measurement with a Bowley gauge and then take the tines of the Bowley gauge and measure inside of the denture, like you would see here, and then add 1 to 3 millimeters for tissue depth, it gives you a rough estimate. So the number one criteria that we see is if we need increased prosthetic space, we're going to flap. If we have enough bone width, we're going to do flapless. Okay, as long as there's prosthetic space. Okay, that's the number one factor for us. If the ridge is incredibly narrow and knife-edged and really ragged, I really do recommend going ahead and flapping, because that's super, super critical. Okay, looking at a couple more things here. How do we assess integration of the implant? So the question is the follow-up. I have broken my bond for too long. This is from George Bleich. So what's important to understand here is that the general recommendation is that when we have a torque value of higher than 70 Newton centimeters, we tend to overload the implant to driver interface. And these implants have been engineered to fracture at around 120 Newton centimeters or so, or maybe just shy of that. So what I don't recommend doing is just testing that, because it is an external hex implant. It won't flower, but that head will break off. I don't recommend going above 70 Newton centimeters. And in fact, if the implant goes down, so if this is your Zest LODI implant, and you're down into the soft tissue, looking something like this, what I recommend doing, and you're torquing right now at 20, 25 Newton centimeters, I recommend backing out that implant, going in with a wider osteotomy, and then replacing the implant so it goes down all the way into place. So I definitely don't recommend cranking too much, but again, I direct you to the surgical videos that are present on the YouTube channel. I'm going to go ahead and jump back here with my slides so you can see. Go ahead and write down this information. That YouTube channel does have a great clinical case of where the implant was too high initially. And in fact, it was a little bit off angle, just a hair, because as the implants sometimes go in, when you hit cortical bone that's dense and thick, they tend to migrate just a little bit. And it'll go through an example of when I encountered this surgically. I've backed out the implant, retorqued it down, still achieved over 30 Newton centimeters of torque, and that allowed me to correct my angulation. So at this point, we're about 6 minutes after 6. We've done a fair job of answering a lot of the questions, and I'd just like to again thank Zest Anchors and DTStudyClub for allowing us to host this webinar, and all the individuals that make my life absolutely spectacular, such as my wife, Dr. Melissa Chotel, who's made considerable inroads and efforts in getting this event possible. So at this, I go ahead and I'll post up my email one more time. So that way, if there's any questions, feel free and email me. And I thank you again for your time and taking time out of your busy schedule. And I think it's almost time for President Obama's State of the Union address. So I took 7 minutes of his time. Hopefully he won't be offended. I thank you for your time. Bye-bye.
Thank you very much, Dr. Shearer, for sharing your lecture and your insightful information with us. We would also like to thank Zest Anchors for making this online course possible, and thank you, our wonderful audience, for your interest and participation. The recording will be posted online within the next 48 hours. You will receive an email notification with a link to the recording. Further questions regarding the lecture today may be submitted directly on the website on the courses page under the Ask the Expert tab. So please go ahead and submit your questions, and Dr. Shearer will be sure to get back to you as soon as possible. Please be sure to visit Dental Tribune Study Club's focused educational platform, www.DTStudyClub.com, and keep an eye out for our growing schedule of online courses. Thank you again to all, take care, and goodbye.